Cost increases are the single largest challenge to our ability to continue to provide high-quality health care to our members, and today we're going to learn a little bit more about what's causing them. We have two experts joining to lead the discussion. The first is Niall Brennan, President and CEO of the Healthcare Cost Institute in Washington, D.C. Niall will be speaking about trends nationally in the U.S. Healthcare spending, and he's also going to cover specific California trend data that's going to be of interest to us. Niall is going to tell you about the Healthcare Cost Institute, so I'm going to leave that to him. I will say that in a past life, Niall led the data strategy at HHS during the Obama years, and I can personally attest to how smart and knowledgeable he is. After Niall, we're going to dive into California-specific challenges. Christoph Stremikis from the California Healthcare Foundation will be leading that discussion. Christoph previously served at the Pacific Business Group on Health, so he understands the purchaser perspective. He also did a tour at the Commonwealth Fund in New York City, which is where I worked before I came to CalPERS. The goal today isn't to decide what initiatives CalPERS should be pursuing. We're going to have a lot of time to talk about that throughout 2020. Instead, our goal is to understand the context, cost trends, and California's unique challenges, as well as potential options for addressing them. And with that, I'm going to turn it over to Niall.
Thank you very much, Don. Hello, everybody. It's great to be here. Don promised he'd say nice things about me if I got up at 2 a.m. Pacific time to fly out here. So here I am. I want to talk about a topic that I'm very passionate about, healthcare spending in the United States. Just very quickly, the Healthcare Cost Institute is an independent nonprofit research organization that has a very unique set of claims data, healthcare claims data, that allows us to understand the healthcare system much better. I don't know how familiar you all are with the healthcare system. Parts of it are privately funded, parts of it are publicly funded. Traditionally, we've been able to analyze the publicly funded systems like Medicare in a lot of detail, but it's been very difficult to analyze privately funded healthcare, particularly healthcare for people who receive healthcare coverage from an employer. This slide gives you a rough sense of some of our data resources. We have about 43 million people that we have detailed information on with employer coverage, and another 40 million people with fee-for-service Medicare. There's been a little bit of a change in our approach in recent years. United Healthcare is transitioning out of its data sharing agreement with us, but we've been very happy and relieved to get additional data from more than 30 different Blue Cross plans. So moving forward, we'll actually have information that we can analyze on 65 million people with employer-sponsored health coverage, which is about 1/3 of the entire market of individuals with employer-sponsored health coverage. We're an independent organization because we do have partnerships with health insurance companies. When people don't like our results, they frequently like to fake and use us or describe us as shills. We define our own research agenda. Our agenda is not influenced in any way by our data contributors, and these are my board members, which are a mix of leading healthcare academics and healthcare business folks. What we do, we analyze the data ourselves, and then we also license it to academics at universities all around the country, and also actuarial societies and leading government agencies. And we're able to do much of this work with generous support from foundations like the Robert Wood Johnson Foundation, Commonwealth Fund, etc. I probably won't surprise many people by pointing out the obvious, that healthcare spending in the United States is a serious problem that is consuming more and more of GDP every year. The second slide illustrates, the next slide illustrates one of the reasons why. The blue line represents healthcare employment in the United States, and you can see that as retail employment has remained relatively steady and manufacturing employment has decreased significantly over the last 20 or 30 years. Healthcare employment has been one long period of uninterrupted growth. And it leads me to really one of my overarching slightly depressing conclusions after many years studying this, that the healthcare reform debate has sort of degenerated into a massive blame game where nobody really wants to take responsibility for the situation we find ourselves in, with 1/5 of our economy accounted for by healthcare spending. Insurers want to blame providers want to blame insurers. Everybody wants to beat up on drug companies right now because they're the fashionable person to go after, and the people who get squeezed are employers and their employees, who pay more and more every year for less and less health care. So these, some more observations. I think people, and particularly healthcare policy folks, are indefatigable when it comes to optimism and new ideas about controlling healthcare costs. But if you take a cold, hard look at the track record, nothing has really worked over a very long period of time. And so we resort to well-intentioned buzzwords like quality, patient responsibility, value-based care, et cetera, et cetera. I'm a real fun guy to have at a party, as you can tell. One of the central points of my thesis is not my thesis at all. It's a thesis by a very famous, now departed healthcare economist from Princeton University, Uwe Reinhardt. And the reason U.S. healthcare costs so much is that the unit cost of U.S. healthcare dwarfs that of similar services in other countries. So he wrote this very famous article called "It's the Price is Stupid." So I'm going to share with you some statistics about the employer-sponsored population and how the money gets spent. I deeply regret presenting 2017 numbers to you in 2020. There's a natural claim lag with how we do our analyses, and this presentation is coming a week before the release of our 2018 numbers. Spoiler alert, nothing has really changed. In 2017, per person spending for people with employer-sponsored coverage reached over $5,600. This was an all-time high, but more interestingly, spending per person grew at more than 4% for the second year in a row, and this happened at the same time that working Americans were actually using the same or less health care. So that's just a graphic representation of how the spending breaks out. So we take all the healthcare claims in a de-identified way for these populations, and we count up all the hospital inpatient dollars and the hospital outpatient dollars and the physician dollars and the drug dollars, and you end up with pictures like this on the right-hand side of the chart. You can see the growth rate from 2013 to 2017. So the way this works is on the right-hand side of the chart, we've taken these service classifications, and so you can see over a 5-year period from 2013 to 2017, spending growth was over 15%. Okay, on the left-hand side of the chart, you can see that the dashed lines represent utilization. So the utilization lines are either at or below zero, with one exception. So if spending is increasing and utilization is flat or decreasing, the reason spending is increasing so much is prices, and I've broken it out there again by these price categorizations. To dive in a little bit specifically on California. Our numbers indicate that California is the 30th highest state in terms of healthcare spending for the employer-sponsored population in 2017 for the population that we're analyzing. So if you have United Healthcare, Humana, Aetna, or Kaiser, those healthcare experiences and dollars are reflected in the number. If it's Blue Shield California or Anthem, they're not. Spending growth in California was actually a little lower than the national average. I believe the 5-year growth rate in California was a little over 12% compared to 15% nationally. Just focusing on professional spending, so that's spending on doctor visits and other ancillary services. California was actually a little bit higher, so if you remember, you were 30th overall for total spending, but 10th highest for professional spending on physician services and the like. And again, this is the power of our data, is that we can begin to disambiguate healthcare spending. So instead of people saying, oh my God, everything costs too much, let's just give up, we can disaggregate and say, okay, well, in this state, the problem seems to be physician spending, but in this state, the problem seems to be inpatient spending, and in the state where the problem is inpatient spending, and there'll be some slides on this later, there's been massive hospital consolidation over 5 years, and we can, more or less draw a line between the hospital consolidation and the increasing hospital prices and the increasing spending. So I want to move now to another product of ours that's called the Healthy Marketplace Index. This is a multi-year project funded by the Robert Wood Johnson Foundation. So what we did here is we took healthcare spending for 112 metropolitan areas in the United States, and we standardized the spending and created an index so we could compare the same market baskets of services in New York versus Texas versus California. And so for the metropolitan areas that we were able to measure in California, depending on the data that we have, you can see obviously there were areas in California, San Francisco, San Jose, that were right at the top of this spending distribution. But there were also other areas like Riverdale, California, where spending was much lower relative to the national average. So if we compare price changes in nationally and in California over the time period from 2012 to 2016. This slide and the next slide are two of my favorite but simultaneously most shocking slides that I think we've done. So if you look at San Francisco, Oakland, Hayward, even though it was a high spending area to begin with, price growth between 2012 and 2016 was almost 20%. You can see the little hatched square there on the chart, and each square represents a different metropolitan area. So you can see that San Francisco had some of the highest price increases over the 5-year period, despite being one of the highest places to begin with. If you want to take some comfort, I'm not just trying to be beat up in San Francisco. Well, I'll beat up in San Francisco a little bit. So in parallel with the 19% price increase over this time period, this occurred when there was actually a 12% decrease in hospital inpatient utilization. So, but you can see that this pattern repeated itself from area to area to area all across the United States. So in literally every metropolitan area we studied, prices increased frequently significantly, and in almost every area we studied, utilization decreased frequently significantly. Those are the red boxes and the blue boxes. So to dive in on some California-specific areas, again here just to try and give these numbers some resonance for you all. You can see that price increases ranged from a low of 10% to a high of 19%, as I've mentioned earlier, and that utilization decreases were really significant, as much as 23% decrease in admissions per thousand in Riverside, California. What we also notice is that price and use, this is a dashboard that we built, and it allows you to essentially look at the differing impact of price and use by type of service in specific metropolitan areas. So we and this is also comparing total spending, inpatient spending, outpatient spending, and professional spending. Again, the takeaway here is, in general, the red line is spending, it's going up. Blue lines are utilization, and they're going down over time. So I alluded to this a little bit earlier. Many experts believe that hospital inpatient spending and outpatient spending is driving a lot of the price increases. Many experts believe that one of the reasons for these price increases is increasing consolidation in hospital markets, where hospitals and hospital systems are merging with each other. So there used to be 4 hospital systems in town, and then there were 2 hospital systems in town, and now there's 1 hospital system in town. Well, if there's only 1 hospital system in town, there's a monopoly, and as that hospital system negotiates with health insurers who are offering products to employers in a tight labor market where nobody wants to be the employer to tell their employees that they can, only go to certain providers. It gives hospitals a lot of market leverage. So what the next series of maps and charts just show is we observed almost all hospital markets in the United States becoming significantly more concentrated over time. So you can see each green arrow represents a metropolitan area where a hospital market became more concentrated, and each blue arrow represents a hospital market area where hospital markets became less concentrated. So you can see some specific examples there in LA and San Francisco in particular, where hospital markets became more concentrated. This is another way of visualizing these numbers, and so you can see that in certain areas, such as LA, went from not really concentrated at all to just becoming slightly concentrated, whereas in comparison on the right-hand side of the chart, San Diego had a pretty concentrated hospital market that didn't change too much over the time period that we studied. I've got a couple of more slides for you all. We also compared the price of C-sections in each metropolitan area. And so this is not the price that a patient pays, but it is the price that an insurance company pays a provider and ultimately passes through to the employer and the employee in the form of premiums for the benefit package. And we witnessed astonishing variation in the price of a C-section, even within the same metropolitan area. So again, if you look at San Francisco, yes, it's a more expensive place generally, but in the San Francisco market, for this population of women with employer-sponsored coverage, the price of a C-section could range from roughly $15,000 to almost $40,000. So this is not a Medicare versus Medicaid comparison. This is looking at people with employer-sponsored coverage. Same story with lab prices, with some of the most egregious variation occurring in Texas. Although there was some fairly significant variation in California as well. I want to highlight some issues here. So I alluded earlier to value-based care, and there's been a lot of faith put in value-based care over the last couple of years, and I think there's possible that some progress is being made in general, and specifically in government programs like Medicare. But the problem is if the price of, even if you're reducing readmissions and ER visits and different things like that, which are all laudable goals in and of themselves, if the price on the residual services that continue to be provided are rising so rapidly, not only are you not making headway against the healthcare cost currents, you're actually sinking further behind. So these spidery-looking charts look at ER facility fee prices in the United States and in California. And so an ER facility fee is the price of admission to an emergency room. And so what we noticed, again, is we track these things over time, analyzed tens of millions of emergency room visits, and we noticed that over time, emergency room visits were much more likely to be coded as high severity and much less likely to be coded as low severity. And so at the same time, the prices on the high severity ER facility fees were increasing at a much greater rate than the prices of the low severity ER facility fees, with the result that when you combine, double-digit increases in utilization with, high double-digit increases in price, you get to treble-digit increases in spending on facility fees for emergency rooms. And again, this is before they you get charged, $100 for an aspirin or a Band-Aid. It is literally the price of admission into an emergency room. Final couple of slides, we looked at prescription drugs for people with multiple sclerosis. If you look at the left-hand side of the chart, the blue-colored drugs were older injectable treatments, and then the let's just call them red and yellow for simplicity's sake, were oral disease-modifying therapies that were introduced to the market. On the right-hand side of the chart, you can see the price increases for these drugs over time, and it's interesting to note that it didn't really matter if it was a new drug or an old drug. The prices for both drugs essentially increased in lockstep over the entire time period. To look at one drug in particular, Copaxone, which was one of the older drugs that gradually had its market share eroded by a newer drug that was, don't get me wrong, easier for patients to take. And Copaxone had a 23% decline in utilization between 2007 and 2015. And over the same time period, spending on Copaxone actually increased by over 70%. Why did this happen? The price of Copaxone doubled. So, the title says it all. I mean, healthcare really is one of the only sectors of the American economy where you can actually lose market share and gain revenue. On that happy note, I will conclude.
Great.
Thank you.
Thanks, now. Chris.
Sure.
Questions for this first part. We have Ms. Taylor.
Hi, thank you very much. I appreciate the honesty. I'll have to say, I think even before, I've only been on the board for about, 6 years now? But I will say even before that we were always being told if we, cut down ER visits, we'll cut down prices. If we cut down inpatient visits, we'll cut down prices. When I got on the board, that was the case. And what you're telling me is somehow or another, all of the people that are profiting off of healthcare have figured out a way to, when we are doing what we're supposed to be doing, which is obviously using hospital services less, they are still driving the prices up. It's depressing, like you said a minute ago. And that's inclusive of the pharmaceuticals, where you said that's the only place where you can lose market share and still make a profit. I'm concerned that we don't have, and I know, Don, you said we were going to discuss solutions at a later date, but I am concerned that this has been an ongoing problem for 2 decades, maybe longer, maybe 3, that we are just letting this continue to occur. Whether it's hospital consolidation, it's selling drugs on the stock market, it's cornering the market. I think, what do you call it? Insurance carriers now are starting to buy each other, so they're consolidating the market. There is one way or another they're trying to figure out to continue to make a profit, and all it does is hurt our members, hurts me. I pay for my health care just like everybody else. So is this, as you guys go through this analysis, are you seeing this as just a way for them to prop up the price? Is there another reason that this is continuing to go on no matter what we do, no matter what we're told the solutions are, and when we meet those solutions, the prices still go up?
Great observations. I mean, really, the bottom line is that too many people are making too much money from the U.S. healthcare system to really effectuate, genuine change. If you define genuine change as bending the cost curve. So, again, a lot of the things that I talked about are sort of like rearranging the deck chairs on the Titanic. And so I think, I don't know too much about the CalPERS experience per se. CalPERS has a lot of purchasing power, and so, but I think that until employers writ large say enough is enough, we're not going to stand for this, predatory pricing. It's hard for me to see how things will change. Now, to the flip side of that is we're in a historically tight labor market. Health insurance is a cherished American workplace benefit, and the few employers who have tried to be aggressive in this area sometimes get burned. Or even if an employer can, just the complex web of arrangements between providers and insurers actually restricts, kind of real solutions to the problem. A large employer went to their TPA about 2 years ago. There was a Wall Street Journal article about this, and they said, we've crunched our own numbers. Next year, we want to offer a benefit package to our employees that covers every single provider in the area except this provider here. And the insurer came back and they said, I'm sorry, the arrangement we have with that provider is that they are either in all of our networks or none of our networks.
So we don't have a lot of control over all of the system. And I will say, you asked how CalPERS is. We're no different than any other employer. We used to be told that we had, the purchasing power of 1.4 million people, but I mean, that's not a whole lot of people when you look at Walmart or somebody else. So
Walmart are struggling just as much as you are.
So we're at the beck and call of all of these prices. It's very frustrating. I know that as we look at this, it can't just be employers standing together, because I think Walmart and JP Morgan have decided to start their own company. Hopefully that works. I don't know how you're going to control those costs, but I really see a problem in general in the entire system, and you're right. I think it's because everybody wants to make a profit off of this, and every time we come up with a solution, they figure out a way around it so they can make money.
Mr. Miller?
Yeah, thank you. Very, very interesting presentation. I've been kind of involved in healthcare activities for many, many years, and I've seen a few things that really kind of baffle me, and this really makes me even more baffled. I've seen a lot of change in what is done inpatient, what is done outpatient, and a lot of transitioning of lower complexity type of stuff to community-based outpatient clinics, and more consolidation of particularly community hospitals. And in one sense, you kind of might expect, that might increase the per visit cost in both arenas. And the other big thing that I've noticed is kind of a shift away from physicians are harder to see for more than a few minutes at a time. There's a lot more non-physician medical professionals and a lot of shifting that, again, would increase the numbers and employment numbers, but not necessarily, physician dollars. And so some of these cost trends, it's just baffling, because unless the numbers that we can't get under the hood for, which is margin on a given service line or procedure, that's the only place it seems to me that money can be going. Because nurses, physicians' assistants, even physicians aren't making the kind of money relative to the rest of the world that they used to. They're not getting, 5-6% per year salary growth, a nurse's aide or a nurse or a doctor. So who is getting all that money? That's...
Again, a great question. I mean, I think to your point on hospital inpatient versus outpatient substitutions. So yes, on the face of it, if care is migrating from high-cost inpatient settings to low-cost outpatient settings, we should save money. Except, and I'm not saying any of this is easy. It's like really hard. But what's happening is on the remaining services in the hospital inpatient, then because hospitals have their own bottom line, so the services that are still happening in hospitals, prices are going up. And then because low complexity things or lower complexity things are migrating to outpatient centers or ASCs, and they're easier to get to because they're in the community. And oh, by the way, the hospital just bought 4 physician groups last year, and the hospital is now saying to these formerly independent physician groups, well, we got to keep these outpatient centers and ASCs full, that more people go to those, potentially go to those outpatient centers, and so you end up just with a situation where we're spending more. Look, I'm not going to also deny that there's an incredible amount of waste and inefficiency in the U.S. healthcare system. We invested $25 billion in electronic health records for hospitals and physician offices, and certainly when I go to a hospital, the only tangible evidence of that I see is a dazed-looking 22-year-old trailing along behind a doctor, because we invented an entire new class of medical employment called scribes, because doctors were like, I'm not spending all my time inputting this information, so we had to hire people to follow the doctors around and input the information.
Ms. Middleton?
Okay. Well, I've heard a lot about single payer. It seems we're moving to a single payee in far too many places. But is there any evidence that there are differences in the growth of costs in systems that are per capita versus fee-for-service?
So, in general, if people are subject to risk or capitation, there are incentives to manage costs. The problem I sort of have is even most of our value-based care models are essentially built on a fee-for-service chassis. So we keep paying, fee-for-service, and then we engage in sort of complex, retrospective back office calculations to figure out what it might have been under more of a capitation or population health experience. But I think we need significantly more widespread adoption of those models to see if they will actually work.
And this may be something for future, but I think we need to have more conversation here regarding what we can do to push the market more in the direction of capitated models. Fee-for-service is one of the few avenues that I have seen where doing something you don't need to do is rewarded, and frequently rewarded very handsomely.
Yeah, one other note to add, I mean, Medicare Advantage is essentially a capitated system, and even with a capitated system, people will find ways to maximize their returns from that system, because you don't just pay a flat capitation fee, you pay a capitation fee that's adjusted according to the risk of the population, and then an entire industry sprung up to maximize what are called individual risk scores, so that you try and make each patient that you're receiving a capitated payment for look as sick as possible, so you can get bonus add-ons to the capitated payments. So it's,
Thank you.
hard.
Mr. Rubalcaba.
Thank you, Mr. President. This was very intriguing presentation. It also shows a lot of, to me, seemingly contradictions and how complex it is. And I mean, I was looking at the ER facility fee prices where you compare U.S. with California.
Yeah.
On the one hand, you see California has lower usage, but the price is a lot higher starting point. So, so I'm not sure the question should be: is it a good thing that? Is it because California has more HMOs or capitated, to use the term there, that you see the slight, that the trend is not so bad on the usage, but the price is, but yet, if that was the answer, why was the price so high? So it's like, you can't figure, how do you get findings from this? How do you explain some of these contradictions? I mean, how can?
Well, sometimes I don't. I mean, again, all of my data reflects the experience of people with United Healthcare, Humana, and Aetna coverage. Some of the overall trend numbers that I reported at the beginning of the presentation do include input from the Kaiser system, but the ER results that you refer to don't include people with Kaiser coverage. So, why does it look that way? For people with that kind of coverage in California, I'm not sure, but that's the way it looks.
I'm sticking with California. I couldn't help but notice that in an earlier chart you showed that the Riverside area had the biggest drop in usage, but also had the highest price, or close to high price. So is that a reflection of? I mean, I don't know. It's like chicken and egg. What happened first? Did the price go up, and that forced people to go use services less, like a barrier to care, or? How do you explain something
So
like
these are descriptive statistics. So, I hesitate to imply causative factors, but, hospitals are and hospital systems are frequently the largest employer in any given company. They're run like private businesses. They have CFOs that like to solve for a bottom line. So if you're seeing your bottom line being affected by lower utilization, and you have the ability to potentially affect that any damage to your bottom line by increasing prices, CFO wouldn't really be doing their job unless they try to essentially make the market, bear it. Somewhat speculative on my part, to be clear, but.
And to add on, and I think Christoph is going to talk about this more in a minute, but it's easier to do that in a consolidated market. So one of the things Niall was pointing out earlier is that when you move to some parts of the country to others, you have tremendous price variation, and one of the inputs there is how consolidated the marketplace is.
Thank you.
Good. Ms. Oliveras.
Thank you. I have some questions just about correlations as it relates to the costs. I'm sorry, what is the correlation between the annual increase in the cost of healthcare and higher education?
Higher education costs?
Mm-hmm.
Gosh, I don't know off the top of my head. I mean, again, the prevailing sentiment from many of the articles I read, both as a professional and as a parent, is that every extra dollar spent on healthcare is a dollar that we're not spending on policing or education, et cetera, et cetera. I mean, there's only one pie, and if one slice keeps getting bigger, the other slices get smaller.
Let me phrase that another way. So I know that the cost of higher education is increasing every year, right? And so many of these positions in hospitals and clinics require higher education. How does that factor into the cost of healthcare?
I think that when people go to medical school, they definitely incur a significant amount of debt, and over time that has led to certain expectations about appropriate compensation for medical professionals. It varies obviously dramatically from a PCP working in an uncompensated care clinic to a spinal surgeon. So I'm not an expert in physician compensation per se.
And there are actually student loan repayment programs for PCPs working in underserved areas. California has that. So
Yeah.
I know that helps to defray some of the costs. It just seems like the cost of higher ed is raising at a similar rate or higher. How has the annual cost of health care changed since it became legal to advertise pharmaceuticals?
Since it became legal to advertise pharmaceuticals, I think most people would agree pharmaceutical spending has increased fairly dramatically. I think that there are academic studies, formally establishing a link between the two. I'd have to, dig them up to make absolutely sure.
Okay, and then I know some insurance companies have lost their nonprofit status. Is that due to profit-making activity or to very high margins?
Again, a little bit, while I use lots of insurance company data, I'm not necessarily an expert on the insurance company market. I believe you've had some conversions here in California, as many other states have, and, foundations have been established, et cetera, et cetera. I would imagine that if a plan is converting from not-for-profit to for-profit status, that it's because it views its not-for-profit status as, restricting its
I meant when it was
ability in some
required by a
way.
regulator. I meant when it was required by a regulator, when a regulator removed the nonprofit status.
Okay.
Yeah, that's much less frequent. Usually it's
Not nationwide.
it's a request, and in those instances, California has been a leader in essentially redirecting those assets to ensure that they're used for some public good. The California Healthcare Foundation, where Christoph is from, is funded out of a conversion. We have some of the largest conversion foundations in the country here in California.
Right. Thank you.
Mr. Perez.
Mr. Molds, I know I'm sorry, guys, I know this isn't really directed to you, but this is informational. Does CalPERS have to administer health for our members? Like by the law or?
That's a great question.
Yes.
Yes. Thank you, Matt. Yes.
I don't like that answer.
Okay.
It's just,
My filter's
it's
kicking
assigned
in, so-
by the legislature to CalPERS to administer the health plan for the state. Whether that's a wise decision by the legislature or not is up for debate, but that's the decision the legislature made. And so that's our duty.
It angers me. Look, I understand that companies want to make money. I get it. People got to send their kids to school, put bacon on the table, except for Kaiser, which is a nonprofit or not for profit. But it's just ridiculous that these numbers are looking like this. And we're talking about souls that we're supposed to protect and make sure that we have health for, and the price is just going up. I know there's some here in the back, some health providers, so quit squeezing us.
Okay, all right, I think that's the final question on that. You can move forward.
Yeah, why don't we go ahead and move forward and turn it over to Christoph.
Do you still want about 10 minutes, Don?
10, 15
minutes. Niall, that was super depressing. And
That's
you,
why they pay me the small bucks.
you are never welcome at a party at my place. My name is Christoph Stremikis. I'm the director of the Market Analysis and Insight Program at the California Healthcare Foundation. We just alluded to conversions here in the state of California. The California Healthcare Foundation was created by one of these health insurance conversions back in the 90s. We are currently, or we are still, an independent, nonpartisan, nonprofit philanthropy. We're based in Oakland. We have offices up here in Sacramento. Our mission is to improve the healthcare delivery system for all Californians, but in particular those with low incomes. Niall showed a lot of data. A lot of it was depressing. I've got a few more data points for you that probably aren't going to cheer you up. But what I want to do is maybe bucket that up and tell a story, or tell a story with three sort of points, or to frame this answering three questions. Number one, I don't think we need to spend a lot of time on, but it's why do we care that healthcare spending is increasing? If healthcare spending is increasing, it means money into the industry is increasing. It means jobs in a lot of communities. Let's unpack that a little bit as to who the we are that we're thinking of and why we might care either as Californians, as PERS board members, as taxpayers of the state of California. Let's sort of define that a little bit. Number two, we do have a lot of data points. Niall has a slice of the market and has done amazing analysis on that slice. There are other pieces of data that we do have, or other pieces of this puzzle. I want to talk through some of the major things that we're seeing at the foundation as it relates to healthcare spending, specifically within California. And then the last bucket, we started to get into this, Ms. Taylor, Ms. Middleton, you had talked about, well, what can we do? We've heard this story before. We've tried different things. Maybe there's a little bit of frustration that things aren't working. I agree with that, and I might push back a little and say there have been things that PERS has definitely done in the last several years that have been successful, and there are things that you can continue to do to try to make a dent in this and make a real difference for your members. But first, the depressing stuff. So one thing Niall didn't show is some of the impact on people. It's certainly implied, but when we poll Californians, we do representative polling of the entire state, and we ask them about the healthcare cost problems that they're experiencing, cutting doses in half, not getting recommended treatments or tests that a provider said they should, skipping dental care. When you add all that up, it's strikingly prevalent in this state. And this is a little bit old data. This is data from last year, but almost half of the state is now experiencing some cost-related access problem. That's not a low-income problem. That's not a middle-income problem. That's not a high-income problem. That's everybody's problem. It's not just people that don't have health insurance. It's people that do have health insurance. These numbers are just a little bit lower if you do have health insurance or you do happen to be higher income, but they certainly don't go away, and this is unprecedented. It's a real problem for everybody. A problem that you'll probably hear again and again, or you've been exposed to again and again, is the way that many people pay or feel the burden of expensive health care in this state, and that's through premiums. This is 2017 data showing you that the average premium for a family plan here in California is about $20,000. I can tell you now in 2018, 2019, when we look at this, it's over $20,000. That's kind of an arbitrary number, but when you match it up against the median income in this state, that's more than a third. you're talking about more than a third of the median income in this state is going to health benefits. Now, there's some important data on this slide that shows the relative share that the employer or the sponsor, like CalPERS, may be paying. On average, that's about 75% here in California, which is relatively generous compared to the national average. But I would go back to a point that Niall was alluding to before, which is there's one pot of money. When you talk to an employer, there is the cost of their labor costs, and that includes wages, that includes healthcare benefits. If this money is going towards healthcare benefits, it's not going towards increases in the workers' wages. It's not going to investments in the business to create new jobs. It's not going to anything else. And so these are costs that are directly borne by Californians that have employer-sponsored insurance. Sort of look at this compared to growth in the economy, and one imperfect measure of growth in the economy is inflation. The line on the bottom shows inflation year over year within California. The line on the top shows the average growth in premiums in the employer-sponsored market in California. When we get to the end of that, it's 2017, and you see the lines are getting closer and closer together, which is probably a good thing. But what it sort of belies is, after years and years of this, looking at growth annually with that margin, it starts to add up a bit. And when you look at the cumulative growth over the last 15 years, you're looking at 250% increases in premiums, which are, again, borne by employers and employers, but really employees. And you look at the growth in inflation or economic growth, and it pales in comparison. It's 1/5 or 1/6 the rate. And this speaks directly to a point that Niall and I think Don made, which is just this increasing proportion of our economy, our economic output, is going towards healthcare. That's not necessarily a bad thing, and we'll talk about some of the nuances to that in a minute, but that is striking. There is no other country, no other industrialized country that has a similar phenomenon. The other way, of course, that people are exposed to the high cost of healthcare is out-of-pocket expenses. And when we look within California and compare that to the rest of the country, we're again, relatively better off. When we look at the share of workers with employer-sponsored insurance, those with a deductible of more than $1,000, it's about a quarter of the population now, a little bit more. That's about half the rate that we see nationally. And that is, I think, another board member raised the relatively high proportion of Californians that are in HMOs. Those on average do come with lower out-of-pocket expenses, and that is part of there is a correlation here. We can't say causation, but there is a correlation here. But still, when you talk to folks, they are really, really hurting with out-of-pocket expenses, and that line is going up, both for the country as a whole and the state of California. And then finally, one of these reasons to care, Ms. Oliveris, I think you had started to raise this a little bit, or Niall, maybe you took it in a slightly different direction. But when we think of ourselves as taxpayers in the state of California, there's a real trade-off that we're making. Money that we're spending at the state level on healthcare benefits is money that isn't going to roads, it's not going to bridges, it's not going to higher education, it's not going to the environment, other pressing public policy priorities. That money can only be spent once. Now, when you look back over the last 10 years or so, the amount of money that the state of California has spent on health and human services has increased about 100%. We're covering a lot more people in our Medi-Cal program, and I think you can argue pretty forcefully that that's money well spent, and we need everyone in this state to have healthcare coverage. But it's an important point that as we're spending money on healthcare, we're not spending it on other things, and this growth in the price, the amount of money that we're spending on healthcare, is significantly higher than anything else. That's all the depressing stuff. Now I'm going to try to get to a little bit of the interesting things that we see in the data, and then this will lead into my last sort of section, which is, well, so what can we do about it? First, sort of a point that I made at the outset, which is there's a lot of different data pieces that we have when we look across California, when we look for data on how the healthcare system is performing. Certainly folks like NILE and the Integrated Healthcare Association, a group that we at the foundation work closely with, have done amazing work aggregating claims and encounter data, so administrative data that's getting generated when someone is going to the doctor's office or filling a prescription. We can get little pieces of that. So NILE's piece of that is some health insurers in the employer market in California, so maybe 3 or 4 million lives, something like that. We can go look to other aggregators like IHA that have slightly more data. We could go to individual payers. Certainly a payer like Blue Shield has data that can help us understand spending. And then there are, importantly, individual purchasers. You CalPERS, are sitting on an awful lot of data. You have an excellent analytics team, a very capable group that has a lot of information and analysis that they can share and let you know where spending drivers are. I will just put in a plug really quick. We, the foundation, are always looking for partners that have data that can help us understand what's going on in California, and you yourselves have a lot of that, a lot of this useful data. And then there are, of course, government sources, and I'll just click through a couple of those in just a second. But we get data from the feds, and there is a big effort here in California to implement what's called an all-payer claims database, which is supposed to be up and running in about 2023. So what do all these different data sources tell us, these different pieces of data when we're looking at spending, what's driving costs in the system? It kind of depends, or the answer to that depends on how you slice this up, or what you're sort of interested in looking at. Are you interested in looking at industry segments? Is it going to pharmaceutical companies? Is it going to hospital departments? Is it hospital outpatient versus hospital inpatient departments? Are you looking at payer types? Do you want to know how costs or spending is changing in Medi-Cal versus Medicare versus the commercial market? Are you interested in type of patient? There's certainly where the Commonwealth Fund, where Don and I worked a number of years ago, was very interested about a decade ago in so-called high utilizers. So who are high-cost patients? Let's look at that way. And depending on where you're sort of slicing these, you get different stories that you can pull out. And I'll pull out just a couple for you real fast. Number one, in the aggregate, when we look across industry segment within healthcare, Niall made this point, prescription drug spending, for a lot of the noise that we've heard recently, is a relatively small proportion of our spending. Now, this is data with a couple important caveats here. This is federal data from back in 2014. And so we're looking back several years, so it is older. And this is on the whole. And so this pie chart will look different if you're looking at the employer market, the market that CalPERS is purchasing drugs in, the market that employers are purchasing drugs in. That slice for prescription drugs will be higher. And I'm not saying that 13% or even 20% is not important. But what I would say is that 2/3 of our spending still is in hospitals and going to doctors. When we look at growth rates, and again, these are big picture in the state of California over the last 5 years that we have data, which is 2009 to 2014, the growth rate in hospital care averaged a little over 6% a year, certainly a healthy clip. Prescription drug growth rate was was lower, 3.8%. But then if you remember, if you click back to the overall rate of inflation and economic growth over this period of time, these are significantly higher. One of the other ways you can look at spending data and know something about healthcare spending in California is by looking at individual person. This is data from the Medi-Cal program that's looking at so-called high needs, high cost patients or high utilizers. And the story here is almost always the same. If you look at across Medi-Cal programs or even across the commercial market, there's a relatively small proportion of people that account for a disproportionate amount of the spend. So here in Medi-Cal, it's around 5% of Medi-Cal beneficiaries are about 50% of the spending. Now, there's been a lot of interesting and important research on this. Two of the things that really jump out to me are, number one, when you're a high utilizer one year, You're often not a high utilizer next year in the commercial market. In the public programs, it's different. But regardless, and especially in the public programs, behavioral health conditions are almost always comorbid with these high utilizers. So mental health conditions, substance use disorder is a real issue and really needs to be tackled if we're going to go after or try to get more help to those folks that are utilizing the system the most. Just a couple more slides, and then we'll sort of end here and open it back up for questions. But another way to look at spending data in California, and Niall was doing some of this, is for individual prices for services and on a geographic basis. This is some data that also come from the commercial market, a study that we sponsored last year. The interesting thing about this, what this is showing, is the cost of a colonoscopy in California. It has been adjusted for complexity of the patient. It has been adjusted for underlying input costs, paying the physician and nurse practitioner wages in different parts of the state. And we see dramatic variation, sometimes 50% or more in the price for those services, and we just can't explain that. And that has important implications about concepts of waste or spending in the system that could be removed without harming access or quality. This dramatic variation that you can't explain is one of those blinking red lights that's saying something is really wrong here. And one of the things, Don mentioned this and Niall mentioned this at length, that we see as wrong is this consolidation. But I would say consolidation is a problem across industries. It's not just a problem among hospitals. It's not just a problem among physician groups. It's also a problem among insurers. And so this piece of research that Richard Scheffler, an economist at UC Berkeley, did for us actually pulled out the different pieces of that. So what is the independent effect of a hospital buying a physician group? What is the independent effect of a physician joining a larger physician group? What is the independent effect of a health insurer buying another health insurer? And what you see is both an association of all of those types of consolidation to underlying input costs, so the price for a specific service, and then really striking to me is the actual cost of the health insurance premium that in this case a subscriber in California is paying for Covered California, but I think could be, you could certainly adduce that to the rest of the market as well. So this, consolidation, it's not, the insurers will sometimes point to the providers will point back at the insurers. What this research says to me is it doesn't help. Wherever it is, it's not helping. All right, this is going to be the uplifting part of the talk, and it will also be the shortest part of the talk. So if I was in your shoes, where would I focus? I think number one is I would focus on value. So we've got a lot. I've just clicked through a bunch of slides. Niall just gave you a bunch of slides. Don and the team can bring you a bunch of data on where you're spending money. Spending is a very, very important part of the equation, but of course, spending is different from value, is different from quality. So you've got to sort of take a holistic look at this. There may be some cases where there's a perfectly fine explanation for why you're spending a little bit more money for a specific service. But I will tell you, on a population health level, when we look across the country, when we look across California, when we look among communities, there is no consistent correlation between prices and quality, and that tells us we have a real value problem, and something certainly needs to be done, and there is a lot of work to be done. That was not uplifting at all. The second thing is to focus on leverage. Ms. Taylor, you raised this. CalPERS has been told you've got 1.5 million lives or 1.4 million lives. You can make a difference in the market, and I would say that CalPERS has made a difference. When you look at some of the reference pricing initiatives that CalPERS has tried over the last several years, there is real legitimate health services research that has shown that's made a difference in these areas that we know are so important, like price. Continuing to experiment with that and use that leverage as a purchaser is vitally important. And I would go further and say there are other potential partners in the state of California that you can work with. You may have heard of Smart Care California, a partnership with the Department of Healthcare Services in Covered California. You're adding on another 1.5 million if you're able to partner with Covered California. You're adding on another 13 million if you're partnering with Medi-Cal. That's a lot of folks, and when you get that type of leverage, you can send consistent signals in the market around value, around quality measures that you want, and so utilizing that, utilizing your relationship with the Pacific Business Group on Health is certainly another thing to consider. And then finally, focusing on data. You guys sit on a very valuable claims and encounter. You have a data warehouse, which tells you a lot about where you're spending money, why you're spending money. You've got an amazing team here that can tell you excellent or very actionable things that you can try and do. And I would just encourage you to continue to utilize that data and look for selfishly partnership opportunities with other organizations that are looking to try to bend the curve in healthcare spending in California. With that, I will stop and apologize for not being as uplifting as I had intended to be. Thank you.
Thank you for the presentation and the insights. And we do have a couple of questions. Ms. Brown.
Thank you. I'll give you a chance to be uplifting, either of you. What are the pros and cons about the ultimate consolidation, which is single payer?
You go first.
I'll let you take that.
I started with pros.
The pros and cons. I'm gonna waffle and not give you a real answer here. There has been a lot of research on where are sort of the waste, where is the money really being wasted in our healthcare system? What is this money that we could pull out of the system without harming access or quality? They've identified, or researchers have identified a few different factors. Some of those factors, some of the most salient of those factors are administrative complexity. Another factor is pricing failures. So we're just paying this colonoscopy prices, or the data that Niall showed you about prices for individual services being all over the place. There is an argument to be made that having a bunch of competing health plans with a bunch of different requirements, reporting requirements, quality measurements, is driving up prices. And some of the research showing, just quantifying that is pretty striking. Single payer addresses that problem. When it comes to prices and prices being all over the place, there is an argument to be made for having one single payer, and then all of a sudden you're standardizing those rates. So there are good arguments, or that seems to be addressing what are problems that have been identified in our healthcare system. Now, there are, of course, drawbacks to that approach, and there are, of course, difficulties in operationalizing something like that. And both of those things, or certainly that last part, is above my pay grade. Help.
Yeah, a lot of it's above my pay grade too. I mean, the con is it'll never happen.
Can you give us a pro here?
Well, I think a pro would be maybe not single payer, but single rater. I just think that I just think that the seismic changes that would be involved in the infrastructure of the healthcare system to convert to a true single payer model are just too much. But if we can engage in other actions to compress this incredible variation in rates that we see, it might give us some meaningful progress. And I think people look to, there's a despair, I think, in many people about the healthcare system, and they look to single payer as like a solution to all our ills. And the reality is there are maybe not no, but very few perfect healthcare systems, and particularly healthcare financing mechanisms anywhere in the world. I am a child of a single payer health system, and I still read the newspapers in my home country, and like every day they are filled with tales of woe about people lying on trolleys in hallways for 3 days before a doctor can see them. Now, I would say, rationing and lack of access to care happens in all kinds of different ways. So do you want people to sit on a trolley in a hospital for 3 days, but then eventually get care? Or do you want somebody not to see a doctor at all because they don't have insurance, or to die because they can't afford insulin? It's a very complex set of trade-offs.
Don, do you have a more uplifting answer?
I will just say this. So when forgive me for this, when Christoph was at the Commonwealth Fund, he was a co-author, and I think at times a lead author on a report that was the most popular report at the Commonwealth Fund every year that it came out, and it ranked healthcare systems in 13 different countries. So the United States was almost, not almost, was last in this report every year, based on cost and quality and life expectancy and all sorts of different measures. The two countries that performed the best and sort of traded off on an every other year basis were the NHS, the National Health Service, which is in England, and the Dutch system. The NHS is a single-payer system. Canadian system, also single-payer, usually did marginally better than the U.S. So single-payer, but towards the bottom. The Dutch system is an insurance-based system. The NHS is a single-payer system. What that has always said to me is that who pays is less important than what they're doing. So what the Dutch do is they control prices, and they regulate insurance companies, and they invest in a lot of really smart things like public health, and they get there built on a chassis that is not dissimilar to the Affordable Care Act. So there are a lot of different routes to getting there. The important part is the what you do, not the big question about who's paying.
Ms. Mitchell?
Thank you. This might be getting a little bit granular, but I want to go ahead and ask it. I came across a 2019 Moody's Analytics study not long ago, and it was utilizing data from the Blue Cross Blue Shield Health Index, and it looked at a 10-year forecast for millennial health. And in that, it said millennials have a higher incident of behavioral and physical conditions than Gen Xers did at the same age back in the day, and especially with major depression, hyperactivity, high cholesterol, hypertension, and substance abuse. And the study, of course, indicated that that's going to lead to an increased treatment and an increase in healthcare costs. In worst case scenario, I think it was 33% higher. And so I'm wondering, have you seen this? Have you looked at it at all? And if so, have you been able to quantify the potential increase in healthcare costs due to that? And I was thinking this kind of relates to your slide 10 that you talked about the type of patient we want to look at, and then the mental health issues on slide 12. And I don't know if CalPERS actually looks at millennials per se, or if this is just kind of a new thing that's being talked about.
Before you respond to Ms. Mitchell, could you kind of wrap it up, because we have a time certain coming up on us? Okay, thank you.
I was not aware of that study, and I'm certainly interested in follow up with you maybe afterwards. Thanks.
Thank you.
Right. Well, thank you very much for an insightful, informative presentation again. And so let's join me in thanking the panelists.